Hello and welcome to this webinar on the latest updates in prostate cancer, hosted by MIMS Learning in association with Prostate Cancer UK. Thank you very much for joining us, everybody. I'm Rhiannon Ashman. I'm the Deputy Editor of MIMS Learning, and this webinar forms part of MIMS Learning's Patient Presentation Pathway for Cancer campaign, which we've been running throughout 2025, and for which we're very grateful to have Prostate Cancer UK as one of our charity partners. We're publishing free learning modules, webinars and podcasts to provide education and empowerment for GPs and other healthcare professionals to optimise earlier cancer diagnosis. So I'm really pleased to welcome our speakers for this evening, who are Dr. Alex Norman, GP and Co-Medical Director at the Surrey and Sussex Cancer Alliance, and Amy Rylance, Assistant Director of Health Improvement at Prostate Cancer UK. They've got an excellent primary care focused presentation for us this evening, including a discussion about the nuances of PSA testing, how to navigate recent changes in diagnostic pathways, and they'll be sharing some insights from the Transform trial, as well as bringing us up to speed on National Screening Committee developments. So welcome now, Alex and Amy, and thank you so much for joining us.
Thanks very much, Rhiannon. Thank you for having us, and thank you all for taking your taking a bit of time out of your evening, as I'm sure most of you have had busy days. So thanks for joining. We're here to talk about early detection of prostate cancer in primary care, and we were just talking before we started. It's busy out there for prostate cancer, isn't it? There's an awful lot going on. It's a busy month. November, lots of men's health awareness, and we've got the National Cancer Screening Committee hopefully coming out with their direction at the end of the month, we hope, to give us a bit more clarity. Not going to sit here and profess to have any of the answers. It's not black and white, it's a complicated space, but we just want to talk through some of the stuff that we're doing with prostate cancer, and myself as a GP who's worked with the charity and doing quite a bit of work at our Surrey and Sussex Cancer Alliance trying to improve men's health. So why are we here? Well, it's a pretty big problem these days. Prostate cancer is England's most common cancer, and that's over 63,000 diagnoses annually. Obviously the most common cancer in men, but it also kills 12,000 annually. It's that second biggest cancer killer, which might be surprising to some. And it's that only high incidence cancer that hasn't got a screening program like bowel and breast and cervical. But we're seeing greater numbers of PSA tests being done. People have been more aware, and sadly, obviously, there are celebrities that are raising awareness, sadly, through diagnoses. Recently, Chris Hoy, and we're aware of many before. But the good thing is it's actually over 500,000 living with and after prostate cancer in treatment, so it is eminently treatable. And as you can see, hopefully, the graph there pointing to the number being treated is increasing. So a little bit about our learning objectives for tonight. We're going to talk about the main risk factors for prostate cancer. I'm sure many of you know them, but we're just going to reiterate that. We're going to talk about the PSA, prostate-specific antigen blood testing, and its limitations, the pros and cons of that. Talk about digital rectal examination, and again, whether we should be doing that or not. I'm going to chat about diagnostic pathways and how they've been modernised. And then I'm going to hand over to Amy about the National Screening Committee and the Transform trial that's ongoing at the moment, supported by Prostate Cancer UK. I'm going to chat a bit about supporting you with information and where you can get information for your patients. So let's start off on risk factors. It's a disease of older age, as you're well aware, over 50 generally, but again, we're always aware there's outliers. Chris Hoy being a case there, but 1 in 8 men are going to get diagnosed in their lifetime. But remember, family history is super important in prostate cancer. You're 2 to 4 times more likely if you've got first-degree relative. So we're not great at coding in primary care, but again, making sure you've got those codes so that maybe down the line, as we're doing risk stratification of patients and reaching out, make sure we're coding those family histories and checking with the patient when we're counselling about PSA testing. And one that we're perhaps getting a bit better is the BRCA1 and BRCA2 associated. So it's those breast and ovarian relatives increases the risk of prostate cancer in the men, which is often not known. And I think, like I say, we're getting better at awareness of that. And obviously patients are getting checked. And there's recently been the Jewish campaign to increase awareness of BRCA in those groups. So we're getting better, but it's all about coding in primary care, as I'm sure many of you are well aware. And then Black men are more likely to get prostate cancer, 1 in 4, so they're twice as likely to get it. And again, prostate cancer tries to raise awareness in a lot of its communications. And that comes to the position statement that came because the Prostate Cancer Risk Management Programme, which you might have heard, is quite limited in its guidance in terms of these high-risk groups. And when Black men have double the risk of prostate cancer, but it's also that they can develop it younger as well. So prostate cancer have strongly recommended that they talk to their GP at age 45 and over for regular PSA testing. That isn't a proactive reach out from GPs, but it's trying to raise awareness. So be aware, Black men may well be coming saying, hi, I've seen this communication, maybe I can have a test, and then it's over to the counselling about the pros and cons of the test. And then we talked about men with the family history, that first-degree relative. We strongly recommend again that they talk to their GP about regular PSA blood testing from age 45. So Black men, strong family history, first-degree relative that might have died from prostate cancer. We're now recommending, alongside the Prostate Cancer Risk Management Programme, they have a chat to their GP about getting the PSA blood test. So we do it all the time, but it's not a black and white test, is it? There's no 100% with PSA, like a lot of tests, but PSA seems to add a level of controversy. But what are the pros and cons? So it really can support that earlier diagnosis, i.e. before symptoms develop. Most prostate cancer doesn't have symptoms. One of our professors locally is adamant that it is so important that we get these tests done, because you just reach out and get that earlier diagnosis, because symptoms means that it's already starting to develop. So earlier means more chance of being cured, and treatment can extend life. Repeat PSA testing might provide valuable information as well. So PSAs generally, and again, this is not always adhered to or everyone's consensus, but getting a baseline PSA in your 50s and 60s, the evidence is that if you've got a PSA less than 1 in that age group, it suggests quite a low risk lifetime chance of getting prostate cancer. So getting that early test in really might help set up things in terms of the future, and so some degree of reassurance. You've probably also heard of PSA velocity. So you might well have that PSA that's 1.5 in your patient, and it's repeated in 6 months, and it's now 2.5. Now, that might be a significant rise, and that might be enough to prompt an advice and guidance depending on the age. But monitoring those sort of PSA changes over time, appreciate might be extra work in primary care, but might just make that earlier diagnosis for a prostate cancer patient. But plenty of cons as well. So it's not specific to prostate cancer, and we're well aware of that. And actually, 3 in 4 men with a raised PSA level, i.e. greater than or equal to 3, will not have cancer. And unfortunately, but it is a small proportion, those with a low PSA will later be found to have prostate cancer, but it is a smaller proportion. And the PSA is just to be seen as that first step of the pathway, because a lot of these men will go on to have an MRI scan rather than a biopsy these days, so they're less likely to have any complications. But that's through advances in the pathway. Other factors that influence the PSA? Well, again, we try and counsel patients on this, don't we? Because you can have that temporary increase due to infection, UTIs, and again, we need to make sure as GPs that we take a good history, making sure that there isn't an infection. It's one of the banes of the urologists is getting those urgent suspected cancer referrals with a PSA of of 12, and we've not dipped the urine. So really making sure that there isn't an infection there. It's not an infection history. Make sure they haven't been exercising, cycling, getting more and more common, and intercourse ejaculation. Just making sure we cancel those. So we're not doing lots of repeat PSA tests. Getting more common, testosterone replacement as well, but particularly the injectable forms can lead to some false readings. So just be aware of that. And hopefully some of you be aware of these. What suppresses them? Well, it's the finasteride, but a lot of people don't come to us to get these meds on the NHS today. They get it online. So just be aware that we are asking these, because that PSA of 2 that might be filed as normal could actually be 4, because they're on that treatment, and age dependent, they might be getting a referral in. And also, again, with issues with a population getting a bit bigger, patients that are obese can give falsely low PSA readings as well. Again, if you're a bit surprised about the reading that comes through and it doesn't fit into referrals, remembering there's that advice and guidance, which hopefully can give you a bit of direction to help. So where do most of the referrals come from? Well, it comes from symptomatic patients, and it all comes back to 2015, the NG12, when 10 years ago, can you believe, we got our suspected cancer recognition referrals. We've come a long way in that time and been through a lot. And this drives most of our suspected cancer referrals. But it was last updated in the prostate cancer section in 2021. And there's then the age-specific prostate thresholds in there. Now, as you can see, this aspect of the guidance, though, hasn't really shifted since 2015. And I'm sure you see this when you're checking NICE guidance, but it talks about consider a prostate-specific antigen test and digital rectal examination to assess prostate cancer in people with LUTS, nocturia, urinary frequency, erectile dysfunction, and visible hematuria. But it feels though this is quite old, and does reflect that the evidence base really is inconsistent and not particularly rooted in primary care data. I certainly don't see a lot of the erectile dysfunction going in as well, and the visible hematuria. We might be thinking of other pathways also, but hopefully this is getting looked at soon in terms of improvements. 2021, they did do some improvements, and they demonstrated where we should be referring on the PSA threshold. So previously they didn't specify figures, but now they have done. You can probably see below 40 use clinical judgment. Again, in our Cancer Alliance, we've actually been talking about flagging at a 2.5 level. That's not particularly to encourage people to do tests under 40, although it does happen. But be mindful that some of those might not be getting flagged that are raised. And then you can see we've got the increasing PSA levels, and over 79, again, using clinical judgment. Again, it's a bit contentious, and the clinical knowledge summaries might be worth looking at as well, in that they've put a bit of different guidance on over 79s, but it's local variation across cancer alliances and regions that you need to be mindful of. What are your local thresholds? What have your urologists and Cancer Alliance decided to refer at? So it's not just down to these. There has been some interpretation, and more than that, it's also your pathology that comes back. Are they getting flagged as abnormal? And what details have you got on there? And while I'm on that, I'm going to just mention, remember, when they've had prostate cancer and you're doing a PSA, these figures go out of the window. You need to check where they are. Unfortunately, we've had plenty of patients in our area where until we changed that, you tick a box that prostate cancer was known in this patient, we missed people that have had radical prostatectomies then presenting down the line with metastatic prostate cancer because their PSA had been coded as normal, and unfortunately it wasn't for them. So not all regions are the same. Be aware. But unfortunately, again, not all urologists buy into this. They're not. They feel as though they're not evidence-based, and that many men that should be referred are not, and perhaps possibly seen as a bit of rationing. Now, Amy, I think you've been involved a little bit with this, quite a bit of controversy around it, around the thresholds. You got anything else you could add on this?
Yeah, I think it's just worth highlighting that the evidence base behind these age-related thresholds is pretty flimsy. And there was some work done by Imperial in London who looked at the men who were referred on their pathway with PSA above 3, and if age-related thresholds had been used instead, how many clinically significant cancers would have been missed. And what they found was that if you start applying age-specific thresholds, you miss a lot of clinically significant cancers, in particular in those older men, because those PSA thresholds keep going up. And so they argue very strongly that actually these guidelines are, really, I don't want to be too controversial, but quite ageist, because essentially what they're doing is rationing access to care for those older men. So we do know that NICE are reviewing some of their prostate cancer guidelines, and they have specifically said that these age-related guidelines are something that's going to be looked at again. So who knows whether in 6 months, 12 months time, we will still be talking about age-related guidelines, or whether we will go back to a single number.
Yes, there was a bit of debate about that with the Get It Right First Time team, wasn't there? It's again, it's a moving target, this, but your awareness of them and your awareness of your local guidelines would be sensible, but hopefully because you're on this, you are. So a lot of men go on USCs, urgent suspected cancers, with symptoms, and we've got a bit of like you say, sort of slightly controversial guidance on that, but we've at least got some. But men without symptoms, which again, how often do we get that patient phoning up, or somebody's having their routine bloods and you get a task asking, can you just add on a PSA? They're a bit worried about it, etc., etc. Well, there was some government guidance, and there is some government guidance from the Office of Health Improvement and Disparities about how to counsel men without symptoms. Remember, this is a reactive thing. There is no national screening program. We wait for the end of November for the announcement, but it is very much men without symptoms have to ask for the PSA, and we shouldn't, as GPs, be proactive in raising these issues with PSA testing with asymptomatic individuals. But it is free to men who request it. Sometimes we get some anecdotal stuff about it. Am I eligible? And sometimes it's a little bit worrying about the response. But the PSA is free to men who request it. But there's from this guidance, there's no recommended PSA threshold. Just a line saying most men have a PSA level less than 3. So it's not that tight a guideline. It sometimes can offer more questions than answers, which is why we discussed it at Prostate Cancer UK, and we felt that although it was available to men who requested it, it excluded trans women and non-binary. And although it asks for GPs using their clinical judgment to manage these asymptomatic men, it didn't really give much guidance about this increased risk of prostate cancer and what GPs should do in these cases. So it's quite limited with that, with the Black men, the family history, and BRCA family history as well. And it basically just said, discuss the pros and cons of the tests, and lent on nice guidance for those with symptoms. So we felt though it could have been more. Digital rectal examination. Again, this is something that has been a bit of a change recently, and hopefully NICE will start to reflect on this going forward. And you might well have seen the article in the British Journal of General Practice that we'll talk about in a second. But it's basically not a great screening tool. It's really not a pleasant examination, and nor is it sensitive or specific, and it doesn't really add any value. That's the thing in terms of a PSA that's high. Nice Guidance in 2019 said that the next test on a high PSA is a multiparametric MRI. That's first line after referral, and that improves the accuracy of the diagnosis and going forward. When to do it? In symptomatic men who have a normal PSA, who haven't got any worrying issues, so we can. Again, a PSA that comes back as okay, I would absolutely ask the patient in to do a rectal examination and try and assess their prostate size, maybe get an ultrasound, etc., if I feel as though that's appropriate. So in the symptomatic, PSA less than threshold, fine. But what we've had some feedback is that mostly it's this deters men. And to bring this article to life a bit more, Amy, you did a bit of work on this, and we got a bit of support going forward. Talk to me about it. Yeah, go for it.
Absolutely. So at Prostate Cancer UK, we spend a lot of time speaking to men and their loved ones about prostate cancer and about getting tested, why they would get tested, why they wouldn't get tested. We did some large scale consumer research, speaking to thousands of men. And the thing that we found was the single biggest factor that stops men having a conversation with their GP is concern about the digital rectal exam. So 60% of men say they are worried about having a digital rectal exam. And of those, 37% said they just would not speak to a GP about prostate cancer because of the fear of the DRE. And so I know, I've done a lot of work around the DRE and spoken to lots of GPs about it. And sometimes what people say to me is, yeah, but isn't it useful because it's an extra check. We know the PSA isn't perfect, so maybe we should just be doing DREs. Doesn't do any harm. But what I would argue is that our insight from speaking to many thousands of men is that it does do harm because it stops men feeling able to have that conversation in their GP. If it's something that stops people feeling able to come forward and ask questions about their prostate cancer risk. And we also do know that it is more taboo in some communities, and our research is that it is more taboo actually for Black men. And so those men who are at highest risk of prostate cancer may be more put off coming for help, coming to have a conversation with you about their family history, about whether it would be sensible to have a PSA test, out of concern that they're going to have an intimate examination that they just don't feel comfortable having.
Thanks, Amy. I think that's really, really clear, and I think trying to get this message across that it is a poor test, and that got the backing of the British Association of Urological Surgeons as well. DRE is a poor test for prostate cancer. It's diagnosed with a PSA as being the first step, then MRI scans, and then biopsy techniques if required. It's basically, there is no need for a physical exam here. Again, on other pathways, things like the FIT pathway for lower GI and bleeding on HRT pathways that we're well aware of as GPs, we're hammered, aren't we? Make sure you see the patient face to face and do the examination. Here, actually, it really is probably doing harm to patients not coming forward who would otherwise come forward. And if their PSA is up, the rectal examination isn't required. So hopefully that's clear. Clearly, you can still do it, and it does give some benefit to other benign conditions, etc. But I think the message is getting out there as well. Thanks, Amy. So a little bit about the diagnostic pathway. Again, appreciate that things change nationally. Not everybody's at the same pace in every region. But I think we're pretty much there across the country in terms of improvements in the pathway. And you're probably aware before 2019, it started with that first step, that PSA. But generally, if that was up, you went for a transrectal biopsy, which unpleasant, not accurate, high risk of infection, sepsis, and just didn't give good enough results in terms of diagnostic accuracy. So what's happened? It's the multiparametric MRI scan. So it's still a PSA, but the multiparametric MRI scan. Remind me, Amy, how many does it cut out in terms of going on for biopsy? Is it about 25–30%, or is it higher now?
So the original research that was used to introduce it into NICE guidelines was 27% of men could avoid a biopsy. But really interestingly, all of our evidence since then shows that number is just going up and up and up. I think as clinicians are getting more confident in the technique. So, you know, there are parts of the country who say they're excluding 45% of men now don't need to go for a biopsy because they're confident on the basis of that MRI image that that man can be safely discharged.
I mean, hopefully it's just going to get bigger and bigger on that, isn't it? Which would be great. And then those that go on now go for a transperineal biopsy, which is much, much better in terms of accuracy and complication rates than the transrectal. And that led to a bit more work by Prostate Cancer UK, because there'd been a bit of a rumour mill about harm following the PSA test. And so another paper was looked at that Amy was part of, where they looked at the data from the CAP and the PROTECT-T trials to look at harms from PSA testing over time. Amy, I'm going to come back to you again. This was quite a big look, wasn't it? 16 hospitals in London, south west of England, to measure how many men. But why did you do this? What was going on?
So I always think it's interesting when you hear something that isn't correct, but you keep hearing it from different places. And I had quite a lot of conversations with GPs about the PSA test, about their concerns about doing a PSA test. And one stat kept coming up that people kept saying to me, well, there's a 4% sepsis risk from doing a PSA test. And I'm very lucky to manage a very competent data and evidence team who spend a lot of time looking at the data around what happens to people in the prostate cancer pathway. And we knew that 4% figure was just massively overestimating the risk of sepsis. We knew it was incredibly rare. And so we started a piece of work looking at, actually, can we calculate how low that number truly is? How rare it is that men do get sepsis. But interestingly, when we started looking at this, because we were deep diving into the data, we started measuring things like, well, how many people have an unnecessary biopsy nowadays compared with back in the days 10, 15 years ago? How many people have a diagnosis of clinically insignificant cancer compared to a few years ago? How many people do get a really serious infection as a result of the biopsy? And the fantastic news was that we found that all three of those things have dropped dramatically because of the introduction of MRI scans and also because of the introduction of safer, better biopsy techniques. Thank you.
And that just leads on to this. Advances in technology reduce the risk of harm by nearly 80%. Okay, 90% fewer men develop sepsis after a PSA test. So significant reductions because of pathway improvement. So hopefully starting to dispel some of that myth. Yes, it does happen. Of course it happens. It's medicine. But it's really changing. Hopefully those legacy beliefs about more harm than good is starting to shift the other way. Maybe not enough for the National Screening Committee, get it. And we certainly didn't look at the long-term harms like overtreatment and mortality reduction, but actually things are starting to move. So we'll wait to see what they say, but definite shifts in improvements. Thanks, Amy. That was really interesting and you know, good that you get that sniff of something, and but until you get the evidence and the data, to dispel it, it keeps running. So good work, thank you. Right, I'm going to hand over to you, Amy, and National Screening Committee, and see where things going with that.
Thank you. So we've teased this a couple of times already this evening, but those of you who are avid readers of news will know, because it has been widely rumoured and teased in newspapers, that the National Screening Committee are due to make a decision on prostate cancer screening at the end of this month. We believe that the evidence base has shifted significantly. As a charity, we submitted evidence for targeted screening programs. So we submitted evidence for targeted screening for Black men and for men with a family history of prostate cancer, where we felt for both of those groups of men, the evidence base was stronger. We know that colleagues at the Institute of Cancer Research submitted a case for men with an inherited BRCA variation. So essentially, we are looking at 3 possible scenarios that are going to happen within the next few weeks. And that is one that, if you just go back 1 second, one that the National Screening Committee say, actually, the evidence isn't yet clear. We can't prove that screening is clinically or cost effective, so guidelines are staying as they are. 2 is that they recommend screening at a population level, so all men with prostate cancer within certain age brackets get prostate cancer screening. My expert opinion on that is that that is an unlikely scenario. We don't think that the evidence base has tipped sufficiently towards that. But the 3rd scenario is that we have targeted screening introduced for any or all of these groups of men at highest risk. And I think, that is where the view is that the evidence is strongest for these groups of men. I think the thing that none of us will know until the end of the month is whether the evidence is strong enough to roll out targeted screening for these groups of men. But I think, and it comes back to the point Alex was making about how outdated so much of the evidence is around prostate cancer, that we have these guidelines that are based on trials that were ran in the early 2000s. But the way that we diagnose prostate cancer today is fundamentally different. And so whatever the National Screening Committee decide in terms of screening, what their evidence review should do is give us a really solid evidence base from which we can update that guidance, from which we can make sure that we're actually giving people the right information to make the right choice for them, which does take me on to my next slide, Alex. So we saw some rumours breaking a couple of weeks ago around what the decision might mean. And it's always interesting because you then see how people react. And there was quite a lot of conversation about, well, if the NSC have said no to screening, that means the PSA is a bad test. And I want to be really clear that the National Screening Committee are not looking at whether the PSA test is a good test or a bad test. That is not their job. What the National Screening Committee do is they weigh up at a population level the total amount of benefit and the total amount of harm. So benefit is really obvious, your life gets saved. And if you ask somebody, well, what value would you place on that? Universally, people put a nice big number on life saved. When we talk about harm, we're talking about things like unnecessary biopsies, so invasive tests that have a small risk of infection. We're talking about things like overdiagnosis and possibly overtreatment. But I think it's really important to say that overtreatment rates for prostate cancer have plummeted, and we have record low levels of overtreatment now. But what that means is that the National Screening Committee may weigh up the number of men who benefit, which will be a smaller number of men who have their lives saved, versus a larger population of men who are harmed. Now, that harm is smaller for each individual man, but if there are many more men who experience unnecessary biopsies or who experience overdiagnosis, the National Screening Committee will say that at a population level, the maths doesn't add up. We are not ready for screening. But the maths is different if you're an individual man, because if you are an individual, actually you can only experience, well, let's be clear, most men who have a PSA test get a normal result and they carry on with life as normal. But for the population who get an abnormal result from a PSA test, they can only experience one benefit or one harm. And we know that there are men who will say, well, actually, that benefit, that potential of having my life saved, that's so much bigger than the possible harm that I will choose to have a PSA test. And so when we as a charity talk about having the facts, that ability to make the choice that's right for you, that's what we're talking about. And that's essentially why the Prostate Cancer Risk Management Programme exists, because it recognises that choices at population level are fundamentally different to choices that individuals might make. But wherever we get to with this screening decision in a couple of weeks' time, we also know that screening on the basis of the current evidence isn't good enough. So next slide, please. Prostate Cancer UK have launched our Transform study. It is the largest screening study in a generation. It is costing £42 million. And it is about finding the best way to screen people going forward. So there are 4 arms to the Transform study. Arm 1 may look very familiar to you because Arm 1 is effectively the current diagnostic pathway. So PSA test, if the PSA is equal to or over 3, then you're referred for an MRI scan. If your MRI scan is suspicious, targeted biopsy. Now, I think it's really important to emphasize the reason why Arm 1 exists is that the National Screening Committee are working off an incomplete evidence base. Nobody has ever done a screening trial about the current diagnostic pathway. So it isn't possible to say right now, definitively, screening as we currently diagnose prostate cancer achieves X, Y, and Z, because actually nobody knows, because all of those interventions have evolved over time rather than being tested as a proper randomized trial. So Arm 1 is about testing the current diagnostic pathway. Arm 2 is asking the question about, well, what if we lowered the PSA threshold? Because we know that PSA does miss some men. We know that some men do have an aggressive cancer and a low PSA. So what happens if we lower that threshold and we give more men an MRI? Arm 3 is essentially a straight MRI pathway. We will be doing PSAs, but only for research purposes. Every man will get an MRI. And you'll notice that the MRI is being called a prostagram. That is very deliberate, echoing this idea of mammograms. So essentially testing out pathway equivalent to the breast cancer pathway, an imaging first pathway. And then Arm 4 is taking a completely different tack. So we know that prostate cancer is a very heritable cancer. So we know that it is a cancer that runs very strongly in families, but that most people do not have the BRCA genes or the kind of single gene that confers a very high risk of cancer. For most people, it's a whole series of small genetic changes. There's up to 400 genes that have been found to impact your risk of developing prostate cancer. You might have seen some coverage about the spit test a couple of months ago. So essentially, this arm is testing the use of that spit test to identify who are the people who have the highest genetic risk of prostate cancer, and let's offer those people screening. So it's a really exciting study. It's going to give us some first results within 2 years, but there is also that long-term follow-up to be able to give us that long-term evidence. So we are almost at the end. I just want to give you a little bit of context about support and information, because we've thrown a lot at you this evening. So firstly, just to highlight some of the resources that we have for you. Prostate Cancer UK have an online learning platform. It's entirely free, it's CPD accredited, lots of kind of bite-sized courses on there if you're interested in finding out a bit more. We also have a clinical update, so that's a monthly e-newsletter. Make sure you can stay on top of what's happening with Transform, announcements from the National Screening Committee, you know, all breaking research. And finally, our Clinical Champions Programme is a clinical leadership programme. So we recruit people for 18 months and we work with them with a kind of educational supportive package to enable them to deliver a health improvement for men with prostate cancer in their area. It's multidisciplinary. We work with clinicians across the prostate pathway. We've had quite a high number of GPs come through the programme in the past. And so if you're looking for your next leadership opportunity, I encourage you to check that one out. Final bit of context, you know, I think a lot of you will know us as a patient support charity. So just to remind you, I think about our key services for patients. We have an amazing peer-to-peer support service, and we hear repeatedly that a lot of men, that is the thing that makes the biggest difference, being able to talk to somebody who's walked the walk, you know, somebody who's been there before them. So if you have a patient who's struggling with treatment decisions, who you just think needs a bit of support, that is a great way to go. We also have a fabulous team of specialist nurses who are absolute experts in prostate cancer, and crucially are not time limited. So I think one of the things that is phenomenal about the specialist nurse service is that people can ring them and can take their time and can spend half an hour, 40 minutes, if that's what they need, to process what they've been told, to think about their treatment decisions, to think about how they're coping with side effects. Our specialist nurses are there for however long it takes. And we have masses of fabulous patient health information, really easily to navigate, website, leaflets, all sorts of things. So.
Thanks, Amy. I have to say, I think your argument is so balanced, and it's really good to hear about the pros and cons and the risks and the individual risk, and making sure that as GPs we're informed about having that conversation, because everybody's risk barometer is different. And I think making sure that we're informed about what's out there and the pros and cons, so that we can then inform our patients well without bias, has come across really clear and rounded there. Thank you, and fantastic on the Transform trial. We just wish it could be a little bit faster, don't we? But yeah, thank you. So in summary, I think these are our take-home points. 5 things. If gotten everything else, these are the things to take home with. Men at high risk of prostate cancer. It's Black men and men with a family history. Think age over 45 and older men over 50. Remember, they might be hearing communications and coming to you to ask for that blood test. The PSA blood test, we get it. It's not great, but it is the first step in identifying those men that would benefit from better testing, like the multiparametric MRI that we've discussed. And things have really improved on those diagnostic pathways. It is absolutely light years away from where we used to be with the multiparametric MRI, and hopefully getting better, and then improved transperineal biopsies, reducing those complications. And we'll see, as Amy clearly outlined, we'll see what happens in a couple of weeks from the National Screening Committee about the benefits and harms, and be interesting to hear what they say. But hopefully in the future, we're going to have even more answers through the Transform trial that Prostate Cancer have really supported, to find out really what is the best pathway for these patients in terms of delivering prostate cancer outcomes. And then hopefully some good support and information there for your patients and for yourselves indeed. So I think that about wraps it up, Amy, unless you've got anything else to say, but otherwise thank you, and we'll hand back to Rhiannon if that's okay.
Thank you both very much. That's been a really fascinating presentation, and thank you for for moving through that so quickly. Lots of information and lots of questions as expected. So I've grouped the questions into sort of themes. So what I'll do is I might kind of combine a couple of them. I'll put them to you, and then Alex and Amy, you are welcome to decide between you who's best placed to answer. So we've had a couple of questions that have been around PSA testing in terms of how frequently or when it would be repeated. So we have had a question that says, how often would you PSA test for risk groups? Would it be every 12 months? If a PSA is mildly raised, depending on the patient's age, would you repeat it, for example, in 4 weeks, or would you refer straight on? And another question that was about how long would a patient have to be off 5-alpha reductase inhibitors before you would repeat a PSA to avoid a falsely low result?
Gosh, quite a few there.
Sorry, tell me if you want to take one at a time, and then I can repeat the other ones.
Amy, if you want to jump in, but I mean, in terms of the repeats, it's quite specific on the patient in front of you and their risk factors, really. And I very much, at the end of the day, am a jobbing GP and reach for advice and guidance from our local urologists. I'm aware there is some European guidance, isn't there, Amy, about where, depending on your age and your PSA level, but it's European guidance, and that's not been initiated. Well, you maybe you know a bit more about that than me.
Yeah, so in Europe, they advise us of what they call a risk-adapted screening interval. So if your initial PSA is very low, you don't have any specific risk factors, then actually they say you can leave it 5 years before you do your next test. But I think if it's a bit higher, if there's more risk factors, that interval gets much shorter. And you know, I think what we do know is that when we look at the 2 big screening trials, there was CAP done in the UK, which took a one-off PSA test, and then there was ERSPC done in Europe, where they tested every 2 to 4 years. And the mortality gain, so the number of lives saved, was much, much bigger in Europe, where they were doing more regular testing. But what I would say, we do hear men talking about, oh, I go every 6 months, you know, and unless there's a real red flag, unless you're really concerned, I don't think the kind of normal monitoring every 6 months, it feels a bit excessive.
So we had the question also about how long would someone have to be off 5-alpha reductase inhibitors before you would repeat a PSA?
I've heard you just double, you don't need to repeat, you just double the value.
I don't think actually that is the guidance. You're right in terms of, I think you just have to be aware and double it rather than actually stopping it, because it actually hangs around for quite a while. So just take it into account rather than changing the medication. It's not like others where you might stop something. That makes sense.
We have a question that was asking if there is a rise in PSA and by extension possible prostate cancer that preceded LUTS, if a rise in PSA and by extension possible prostate cancer precedes LUTS, how far in advance might that rise precede the symptoms?
So the evidence base around the link between symptoms and prostate cancer is really controversial. And part of the reason it's really controversial is that most men who are diagnosed with prostate cancer are over the age of 60. And a lot of men over the age of 60 experience LUTS. And so there is this huge, essentially, contamination, because you have a population who are experiencing lots of LUTS, and you have a population who are at high risk of prostate cancer. The key message that we want people to take home is that no symptoms doesn't mean no prostate cancer. And there was one study in particular that looked at people who had an elevated PSA and whether they had LUTS or whether they didn't have LUTS. And they found that actually the people with an elevated PSA who don't have LUTS were more likely to have a clinically significant prostate cancer. And so essentially what we just want people to know, don't wait for symptoms. Symptoms are not a good indicator of prostate cancer risk, but lots of men who have prostate cancer will have symptoms because lots of older men do have LUTS.
I have a question.
There's very few asymptomatic men, really, unless they're coming in their early 50s. You can generally get something out of them, but yeah, absolutely, it's that the symptoms are a bit of a red herring here, aren't they, in terms of trying to get early diagnosis.
So I think I probably know what the answer is going to be, though, but there was a question that said, is there any place for using the IPSS?
In terms of prostate cancer, probably not, no. Do I use it in patients that come in because of most of the time it isn't prostate cancer? Yes, regularly use it because it's a good objective scoring system that patients can really objectively say, actually, because invariably you're popping them on tamsulosin to try and help their LUTs, or even finasteride once you find out that they've got a large prostate, and they can really see the difference. But in terms of prostate cancer expectations, no, but I'm often using it even so if they're coming in symptomatic.
Few questions on DRE. Does DRE affect PSA? And if so, how long would you need to wait before you would perform the PSA test? And also, does PSA vary with the time of day?
I mean, the first one, Amy, and correct me if I'm wrong, is the evidence is fairly sketchy, but most of it is that it doesn't really affect it, and it doesn't affect it to any significant level that you would have to worry about delaying that PSA blood test a week or two. So it shouldn't matter on that front. Amy, is that?
Yeah, absolutely. I remember one of our professors who was involved in our PSA consensus made the point that, you know, there are various things that might cause small raises in the PSA. We talked about sex and exercise and all of these things, but he says, you know, a PSA is better than no PSA. And so if your patient turns up and you think, actually, with getting a PSA, or you cycled to the surgery, you know, are they going to come back? Is it better to just get a PSA? Because actually those raises are pretty marginal. Yeah.
And once you've got them, you want to get the test, don't you? Often, again, it's that cohort of men that they've come once, they might not come again. Let's try and make sure we do the needful.
Yeah, that makes sense. We have a sort of comment that says, anecdotally, most men that I see actually do want to have a DRE as part of their assessment if they're coming in to discuss their health, plus a risk and an exam is what the patient group seem to find helpful. I
think that's the great thing again about being a GP is you can flex and you manage your community expectations. Just because some studies have shown it doesn't always mean that that's the same for every individual. So it's still a test that finds cancer and can find other cancers as well. And we mustn't, I think we are moving away a little bit too much from clinical examination techniques and clinical acumen. So yeah, if that's appropriate, then go for it.
And staying with the examination techniques aspect, we had a question that said, in the USA, I think they perform DREs standing up, whereas we do lying down. Is there a reason for the difference in technique? Is one technique better than the other?
Can't comment. I was always taught lying down, I have to say, through medical school. I didn't even know there was a difference. So I can't comment on that. I wouldn't have thought so, thinking about it. And perhaps it's just, different countries teach different ways. But Amy, as far as I'm aware, there's no difference. I can go back and check from the urologists. They'd know more than me on that front, but I would doubt it.
Thank you. So a question on to MRIs. What is the sensitivity of MRIs in identifying prostate cancer?
Well, Amy, I think you alluded to that a bit, didn't you? Go for it.
So the original study found that they could exclude about 27% of men, and that then if you think about the 3 and 4 men with a raised PSA don't have prostate cancer, that means that actually still the majority of men who were going for a biopsy didn't have prostate cancer. However, what I would say, working with the clinicians on our clinical advisory group, they now talk about much more of a over 50% chance of finding clinically significant cancer on biopsy. So an MRI isn't definitively saying this is definitely cancer, but it is saying this is an area of suspicion, and it's an over 50% chance that we're going to find something clinically significant. But that does vary a bit around the country, I think, in terms of how confident the doctors feel about discharging without doing the biopsy. And I think there are certainly areas of the country where they've been doing it for longer, they're more confident in knowing which men to discharge, whereas in other areas there's a slightly more, let's play it safe, let's do a biopsy.
Thank you. Talking about screening then, we had a question that said, isn't targeted screening going to be difficult? If you are a Black man, that's fairly straightforward, but how would somebody prove a positive family history or a family history of BRCA genes? Isn't it dependent on accurate medical records and patient honesty?
Yeah,
absolutely.
It's primary care coding here, and that's why it's a really difficult decision, isn't it? Because how are you going to do it if that's what you decide to do? So I mean, Amy, your team's probably thought of that, but a lot of it is going to be, so when we've done risk stratification and case finding for other cancer groups within practice and PCNs, you're so reliant upon the coding, the lung cancer screening. Just making sure that people are coded for smoking is really important, so they can be drawn out, let alone a BRCA family history, a family history of prostate cancer. It is in there in EMIS, and Ardens are supporting that, and I think it will improve. But yeah, it's going to be tricky. Amy, if you thought about
it. I think what I would say, I know having a conversation with some of the people on the National Screening Committee a while back around this, and you know, they talk about BRCA being the easy one because it's the one thing that is scientifically definable, because you can scientifically identify whether somebody has a BRCA gene variation or not. But both Black ethnicity and family history are much less clear cut. I think particularly on the point around Black ethnicity, what I would say is that there's a lot of evidence around Black men's higher risk. They're higher risk of a late diagnosis, they're higher risk of a diagnosis at a younger age, that actually they're less likely to get NICE recommended treatments, that there's all sorts of ways that Black men fare worse in terms of prostate cancer. And all of that evidence base is based on self-reported Black ethnicity in NHS records. And so my argument very strongly would be that if the self-reported ethnicity in NHS records is enough to demonstrate double the risk of dying from prostate cancer, then actually self-reported Black ethnicity in NHS records should be enough to trigger a screening intervention.
Yeah, that makes sense. Thank you. So we have a question that says, a patient in his mid-60s with a PSA of 4 and a strong family history of prostate cancer. The MRI scan reported inflammatory changes. Do you think a biopsy should be done given the family history?
So this is a sort of an active case, but I mean, in the sense they've gone through on their PSA and they've had I suppose that is up to the team looking at that. I couldn't comment on sounds like a political answer, but on a specific case like that, and I would probably be taking some advice and guidance if there was family, if the GP was concerned, the patient was concerned that perhaps they didn't feel as they'd been investigated thoroughly, then advice and guidance from the urology team that had delivered the care, but I couldn't be more specific than that.
So I think we've got time probably for one more question, and I'm going to put this one in because it's quite forward-looking, and it's, will we be using AI in the diagnosis of prostate cancer?
Absolutely. Yes, we already are. So there's a big study that's just launched, funding by NHS England, using AI to read MRI scans We know that AI use in pathology is growing all of the time. We're funding a big study looking at using AI to drive better consistency in pathology in prostate cancer. Yeah, AI is already here in prostate cancer diagnostics, and it's only going to become more prevalent because it's a very high volume condition and because it's a lot of reading images, and computers are good at reading images.
Did you have anything to add, Alex?
No, I was just trying to think. But it doesn't quite fit. It slightly goes with primary care coding in terms of, I feel as though there's just so much rich data within our primary care records, and it's about pulling those patients out before they reach us. And I appreciate all the concerns over AI and data protection, etc. But I feel as though screening is chucking lots of people in a lot of the time and not being smart and specific. How do we do it smarter with AI? But that's often the sort of vaguer patients, whereas here we've been talking about asymptomatic patients, so you're not trawling notes with vague abdominal pain, etc. So it doesn't quite fit in terms of trying to use the power of AI that can just get through so much data quickly. But I do think AI has got a role once the regulators catch up in finding the high-risk patients, which is why we do need to keep coding well, keep making sure that we give our patients the best chance when these techniques and algorithms come through to find those high-risk patients to get them the best test quickly. So hopefully. But yes, I at the moment, it's Amy's in terms of the radiological aspect is going to be fantastic.